So depression in children and adolescents is a huge topic. We could do a 15-week graduate course on it, and we're going to do an hour-and-a-half presentation with room for questions. And so I say that to let you know that there's going to be some material that's left out. And that's by design, because in order to cover such a broad swath of material, we have to sort of choose whether we go deeper or go broader. And I'm going to try and thread that needle as best as possible so that you walk out of here with some substantive information, but also across a kind of broad variety of domains there. To give you an overview of what we're going to talk about what is depression, just sort of simply what are we talking about when we say depression, distinguish between the symptom of depression and the diagnosis of depression. We're going to talk about different subtypes of depression, causes, risk factors. We're going to discuss treatment options and talk about what you as parents can do, the options that are available to you. I will, as Mary Beth said, I'm happy to take questions. I think we're looking to have most of those be toward the end of the presentation, and so I'm going to be building in room for that. I will finish early so that we can accommodate those questions. I'm happy to take any questions you have. What I won't be able to do is diagnose your child. And I say that in all sincerity because a lot of people, I imagine, are coming here with concerns about their children, and I want you to know that I'm happy to provide information, to provide guidance, and to share knowledge. But without examining a child, it wouldn't be proper for me to say, well, it sounds like your child has major depression, you know? So I can give you the guidance to say, here's where I think you should go, and those symptoms sound concerning to me, and here's what I'd recommend for you. So I don't want you to think that I'm somehow neglecting the question if I don't go that step further to try and provide that kind of information. Okay? That makes sense? Any questions at the outset? All right. As Mary Beth mentioned, I'm a supervising psychologist with FCPS. We've got about 170 psychologists in the school district. There are 3 senior supervising psychologists, so I supervise between 55 and 60 psychologists across the different regions that we have here. I also work as a licensed clinical psychologist in private practice, where I treat primarily children and adolescents and some young adults across a wide variety of conditions, including depression and a variety of the depressive disorders. Okay. What is depression? Depressed mood. More than just sadness. I want to emphasize that because depression, as many other mental health conditions, have come into the vernacular. People use it as just sort of a common saying. I'm so depressed that my favorite show was canceled. You know, I'm so depressed that there wasn't ice cream tonight for dessert. And I think we want to distinguish between being sad or being bummed out and being depressed. Sadness is normal. Sadness is typical, it's conventional, and sadness is typically characterized just by kind of a low mood or a sense of regret over something, and it tends to pass. Depression is a lot more comprehensive, and it's a lot deeper. So looking at the symptom set that we're looking at right here, there's a variety of points here. We're going to go into them in a little more depth later on, but just to give you an overview, loss of interest in previously enjoyable activities, things that someone used to enjoy, now they're no longer enjoying or no longer enjoying as much. The term for that clinically is anhedonia. It's hedonia having to do with hedonism, taking pleasure in something, and the negating prefix. So anhedonia, fancy clinical term, basically just means I'm not enjoying the things that I used to enjoy. A sense of emptiness, a turning inward, being distracted by one's own thoughts, or sometimes an outward turning of being impatient, being irritable. Pessimistic about the future. If we're looking at the thought patterns of someone who's depressed, they tend to be negative thoughts about yourself, about your world, everything going on around you, and about your future. Difficulty being sociable and affectionate. Decrease in energy and motivation, very common, and a preoccupation with self-doubt. Now, any of these alone is not a cause for concern. In fact, many of you, right, if I were to poll you right now, I'm sure many of you would hit a few of these going on. Doesn't mean you're clinically depressed. And that's why we're making a distinction between a symptom and a syndrome. All right, if we look at each of these individually, they might be concerning, but they might not be indicative of a disorder. What we look at is for a pattern of these, and we look at duration, intensity, all of those factors to get the sense of what's the barrier between a normal feeling of unpleasantness and a clinical diagnosis of depression. Okay? So sometimes being depressed is normal, and we wouldn't diagnose that as clinical. If your child is going away to sleepaway camp for the first time, and they're spending that first night and they're not with you, and they're experiencing some of those symptoms that we talked about earlier, I wouldn't classify them as depressed in a clinical sense. I would say they're feeling depressed. But that's a normal reaction to an abnormal circumstance. And when we're confronted with stressors, we often do exhibit symptoms of depression. I think grief is probably the best sign of that. If we were to go through, without the duration criteria, if we were to go through the symptoms of depression anytime a loved one died or the loss of someone close to you, we would meet those criteria. The reason we don't diagnose that as a disorder is because it's expected. We expect that to be the case. Now, there are some differences between grief and depression in the sense that with grief, the mood tends to wax and wane. You can have really, anybody who's experienced this knows it comes in waves, right? You might feel awful at one point, and then if you've been to a funeral, you can tell later on people might be laughing, talking about memories, and then feeling awful again. If you're depressed, it tends not to come and go as much. It tends to be more consistent, and there doesn't necessarily have to be a triggering event that leads to it, which we'll get to a little bit as well. When the depressed mood is accompanied by other symptoms, that's when we talk about the syndrome. Medically, we could talk about this in the sense of if your child has a fever, that's a symptom, right? It's not an illness. We won't say your child's diagnosed with fever disorder, right? They have a fever. But if they have a fever and a sore throat and a runny nose and a cough, then we might say, okay, are we looking at the flu or are we looking at a bad cold? It's the constellation of symptoms that make the illness or disorder. So depressed mood is the same sort of thing. It's a symptom. By itself, it doesn't tell me that much. If it's accompanied by a bunch of other things, then we start to look at something that might be more indicative of a disorder. Okay? So some of the symptoms of depression in terms of the disorder itself, the syndrome, as we might say. Mood symptoms, depressed mood, which we talked about before, a pervasive constricted quality of the mood. What we mean by constricted is typically our mood kind of waxes and wanes, gets happy, sad, everything in between, depending on the events surrounding us. We're reactive to our environment. A lot of times, not always, but a lot of times, individuals with depression lose that normal reactivity of emotion, and their emotions tend to be more constricted. So what you see is people who are kind of generally non-responsive to something that you might have otherwise seen them enjoy, they're still at that kind of low level. However, other times you see kind of a hyper-reactivity in the sense of people are really irritable. Hair trigger responses. It takes very little to get the person upset. All right? And in kids, you tend to see irritability a lot more often as a symptom of depression. Anhedonia, we discussed feelings of guilt. A lot of times people rightly or wrongly blame themselves for those feelings. There's something wrong with me. I'm a problem. I'm a burden. I don't belong. Those are common thoughts and feelings that you have. Loss of interest in usual activity. Social withdrawal, also common. None of these are always present. They are just more likely to be present when we're looking at the syndrome of depression. And suicidal thoughts, we're going to talk about suicide a little bit more later on. Again, another thing we can give a whole presentation about. I don't want to get too much into it here, but we'll discuss a little bit about when is it present in depression, when is it not, what does it mean, what do we do in response to that, okay? Cognitive symptoms. Depression isn't just limited to emotions. All right? Depression impairs our cognition. It impairs our thinking. Intense emotionality tends to disrupt our ability, or what we call our executive functions, the kind of higher level thinking skills in the prefrontal cortex that allow us to think and organize and plan and process. And when you're feeling high levels of emotion, that tends to disrupt those processes. And we know this if I were to ask you about how clearly you're thinking when you're riding in a car and stuck in traffic and someone cuts you off. You're much more likely to say something that you might not otherwise say if you were calmly reflective. And why is that? It's because you're upset, you're amped up, right? If someone is depressed, their emotional system is taxed. They're experiencing intense levels of emotion. So it's kind of like you're stuck in traffic all the time. And so their ability to think and their ability to process is affected. So you're going to see poor concentration. It doesn't mean they have ADHD, or it doesn't mean that they're not motivated. They might have ADHD, but depression by itself can impair concentration pretty significantly. Again, imagine a time that you felt extremely upset or sad or bereft. It was probably hard for you to go about your daily tasks. That's depression, except always. Poor memory. If you can't concentrate, you're not paying attention. If you're not paying attention, you're not encoding information. If you're not encoding it, you're not storing it, and you can't retrieve it. So that's kind of a byproduct of poor concentration. Indecision, slowed thinking. Your thinking tends to be a little more laborious, it's more effortful, and loss of motivation. Again, none of these things by themselves are indicative of depression. So I don't want you to think, well, my child's not motivated, so they must be depressed, or my child is indecisive, so they must be depressed. We're looking at the syndrome, we're looking at the cluster. Physical symptoms. Sleep disturbances. Sleep disturbances are extremely common with depression. Sometimes you get a little bit of a chicken and egg phenomenon, where if someone has disturbed sleeping, they're much more likely to get depressed. And if someone is depressed, they're much more likely to have disturbed sleeping. So one of the first questions I ask when I'm dealing with depressed children or adolescents is, tell me about your sleep. And the problem with that is most of them say it's really bad. And so kind of dealing with which came first is an important question. Did the sleep trouble precede the depression? Did the depression precede the sleep trouble? Sometimes it's insomnia, sometimes it's hypersomnia. Some kids with depression have a very, very hard time sleeping, or they can fall asleep easily, but they'll wake up and they can't get back to sleep. That's a pretty common syndrome of depression, where they'll wake up very early in the morning, depression tends to be at its worst at that time, and they just can't get themselves back to sleep. Other kids, they're sleeping 15, 16 hours during the day. Both of them can be indicative of a problem. Appetite disturbances, weight loss or weight gain, also potentially indicative of depression. Fatigue, headaches. Broad, right? So by themselves, they're not particularly informative, but collectively, it helps us better understand what it is that we're dealing with. So depression, we've got mood symptoms, cognitive symptoms, and physical symptoms all clustering together. Make sense? Okay. Let's talk about some of the key aspects of depression. Depression represents a change from previous functioning. And this is important. If your child always sleeps 15 hours a day, that's a concern by itself, but it's not depression, okay? That's their usual. If your child always has a poor appetite, if they're always irritable, those don't indicate to me depression. Depression is preceded by a change in normal behavior. So if you're saying my kid's just not themselves, that to me indicates a concern. Something has shifted, their energy level, their motivation, their interest level. If you're seeing that they used to sleep through the night and now they're having sleep problems, they used to be really kind of joyful and energetic, and now they're sluggish and not motivated, that's when we start to look at there might be some sort of a difficulty. So we're looking at a shift from normal patterns.
So a great question. So is the change generally rapid or over time? Or?
So the question is whether the change is rapid or whether it occurs over time. And I'm going to give you a typical wishy-washy psychologist answer, which is both. It depends. For some, it can be a fairly rapid shift. For some, it occurs over time. Typically, we're looking at a somewhat gradual shift, but it depends on the kind of depression we're talking about. And I'll get into that a little bit later. If it's a major depressive episode, it's a pretty fast shift. If we're talking about a persistent depression, that could take some time. Also be mindful of when this is occurring. If we're talking right around puberty, then kind of all bets are off in terms of making an immediate diagnosis. So there's other factors that come into play. But good question. Kids are often not attuned enough to their emotional state to detect a change when it occurs. So if you were to ask them, has anything changed, they might say no. Everything's the same. We rely on outside observers to kind of help corroborate these reports. Even if kids know that something's changed, sometimes they don't have the language to express it, and that's an important thing too. So when we're trying to get a sense from kids about their opinions, we can't always ask them straight up, how are you feeling? They don't always know how they're feeling. They know what it feels like, but they don't know the words for it. They don't know how to label their experience. Okay. We hit on this a little bit earlier, but it's a good point to emphasize that depressed mood in kids and adolescents often comes across as irritability. It's one of the more prominent symptoms in children and adolescents, and as indicated, so our Diagnostic and Statistical Manual of Mental Disorders, the DSM, which is what clinical professionals use to diagnose mental health conditions, specifies that irritability in children and adolescents can be the most prominent feature relative to a depressed mood. So if we're thinking, well, my child's not depressed, they're just constantly snapping at me and they're always voluble and they're kind of hair trigger responses to small things and they have huge eruptions, that's a concern too. Often the depressive feelings can be frustrating, they can be scary, kids don't know what to do. Kids are hyperreactive to begin with, they have a little bit of a shorter fuse, and so that tends to be a prominent response that we deal with. Anhedonia, again, a defining feature. It doesn't mean that kids aren't enjoying anything, but a lot of times they're enjoying what they used to enjoy less, or they no longer find it interesting. And it's not just a phase like I'm no longer interested in playing with action figures or dolls, but it's like, really, this is something that would have otherwise brought joy to me, but now I just can't find it in what I'm doing. We talked a little bit about this, the constriction of mood. This, again, goes two ways. Either they're hyperconstricted or they're hyperreactive. With the constriction, a long time ago, AM radio stations used to give out a free radio with the catch that it could only receive the signal of that AM radio station. And so it was kind of fixed at that's the only signal that it could receive was that signal. Depression, the constriction of mood and the constriction of sort of your typical mood state is analogous to that. They're only receiving the depression signal, and they're not really receiving anything else. The explosive reactions is kind of a variant on that. They're still only feeling depressed, but instead of turning inward, it's coming outward into these massive blow-ups toward you, and the sense of irritability in between. And that could be its own subtype of depression that we can discuss a little bit later. But either of these, if you're falling at either end of that spectrum of just feeling empty and depressed versus feeling pretty consistently hyperreactive, explosive, irritable, those both are suggestive of depression. But again, change, right? That typically represents a change. If your child is usually irritable, does that mean that they're depressed? Not necessarily. That could be a temperamental factor. If you knew that your kid from very early on was always a little bit moody, a little bit touchy, kind of a hard time, slow to warm up, that's not necessarily a disorder. That could be more a function of their temperament. We want to see what does that co-occur with. A preoccupation with negative thoughts. Thinking is an important part of depression. That sounds like a silly, axiomatic statement, but since the 70s, when we learned about cognitive therapy and the advances in treating depression by not just addressing emotions or behaviors, but addressing thoughts, we realized that certain thought patterns tend to coincide with depressive thinking. And so thoughts of inadequacy, regret, hopelessness are very common among depression, in the sense that a person just doesn't measure up, or that they're a burden. Despite whatever objectively you might see. You might say, well, no, you're getting, all A's, and you're on all of these teams, and you're so well liked by your friends, but what you're seeing is not the same as what they're perceiving. Worries about not measuring up, thoughts of guilt, thoughts of blame, feeling lazy or worthless. If we look at the automatic thoughts that come up for kids, a lot of times what's underlying their thoughts and feelings are thoughts of just, I'm not good enough, I'm worthless, I'm unlovable. It's hard for them to articulate these thoughts, but they tend to be often at the core of what it is that they're thinking or feeling. Now, if you have an 8-year-old who is dealing with these thoughts and feelings, it's going to be very hard for them to be able to articulate something like that. So thoughts aren't always readily accessible. And it's just something to bear in mind, that just because they don't self-disclose doesn't mean they're not experiencing their developmental variation on thoughts like this. Okay? All right, so before we get into the subtypes, any questions on symptoms that we just talked about and the clustering of those symptoms? Yes.
We have the cognitive and the emotional. Are all three necessary to be present, those three different aspects, or can depression occur without the thinking process?
Right. So the question was, we had mood symptoms, cognitive symptoms, physical symptoms of depression. Do you have to have all of them in order for a diagnosis to be made? No. The answer is no, you don't. The way that diagnoses are made is you're given a set of maybe like 9 or 10 symptoms, and a child or adult with depression has to meet 6 of them, with 2 being required. There has to be some depressed mood present, or some loss of pleasure or interest in activities, and in children that can be more irritability as opposed to the depressed mood. In terms of the other symptoms like difficulty sleeping or negative thoughts, are those required in terms of a diagnosis? No, they're not, because depression presents differently in different people. They're common, but not necessarily diagnostic. So there's a lot of kids who will have their variation of depression because they have symptoms 1, 2, 4, and 6, as opposed to symptoms 2, 3, 5, and 9. So it can look a little bit different. All right. Was there another question?
Yeah, I just wanted to ask about the duration by which these symptoms will take place. Is it like a few months?
Yeah, and that's a great question. The question was, how long do the symptoms occur? That actually feeds into this piece, and so it's a nice segue, because the different subtypes of depression have different symptom durations pretty significantly. And so I'll weave the answer to that question into this piece moving forward. Okay. So these are 5, really 3 subtypes of depression. Bipolar is technically not a depressive disorder. It's considered one of the bipolar disorders, but it involves depressed mood. That's not important information. It's sort of a technical, clinical piece. Depressive disorders are major depressive disorder, persistent depressive disorder, disruptive mood dysregulation disorder. But the bipolar disorders also involve major depression or a persistent depression. And so I'll talk about those as well in the discussion of this. Okay? So major depressive disorder is kind of the most commonly encountered one. Key question for this one is, does your child ever get so depressed that he or she can't function? And it's really at that level. A major depressive disorder involves a major depressive episode, which lasts at least 2 weeks, and during which you're experiencing profound apathy or lack of energy, or conversely, agitation, irritability, restlessness, and raging. Child loses the ability to think clearly and concentrate and make decisions. There's that anhedonia piece. They seem drained of pleasure, interest, and excitement. Disturbed eating and sleeping. Thoughts are slow, heavy, and dominated by hopelessness, worthlessness, and guilt. Major depression really does impact your ability to function. Someone with a major depressive episode really has a hard time being able to manage in any everyday environment. If they're functioning at all, they're functioning very poorly. You can't hide major depression. It's pretty overt. Change is key. Again, you're looking at a deterioration in functioning across a broad variety of domains. Kids' academic performance could go down, their motivation can decline, their social engagement can decrease, and problem behaviors can start coming out in the absence of a history of acting out. If your child is not typically someone who acts out or gets into trouble, but you start seeing those problem behaviors come out, that could be somewhat indicative of a major depressive episode. Now, again, we have to distinguish this from the normal lows and temporary stress reactions. If your child just lost a best friend, or if they just broke up with their girlfriend or boyfriend, that's not the time to make the diagnosis. We're noting that that's a reaction to circumstances. It could be a severe reaction to circumstances, but it's still a reaction to that and not a rising of its own accord. Now, if 3-6 months later they're still feeling that, well, then we might look to say that's diagnostic. But we don't want to call a normal reaction to an abnormal circumstance disordered. Symptoms must cause clinically significant impairment, distress or impairment, which basically means that if you ask what's the line between feeling really, really bad and being depressed, the short answer is, does it cause clinically significant distress or impairment? Now, what does clinically significant mean? It's subjective. Really, we look at how much is it disturbing you or your child's ability to function, how much is it distressing to them what they're experiencing, and how much is it affecting their ability to be able to get by academically, socially, emotionally. Okay?
So one more question about your previous slide. So the symptoms you mentioned there, do they occur across multiple environments, i.e. home, school, and do they have to occur across the same intensity?
So the question was whether the symptoms that we talked about have to be present across multiple environments. Not necessarily, but they're likely to be. At the same intensity level, it depends. If the child is around friends, they might not show as intense symptoms, but they will still be there. There's no environment for depression in which it's not present. It's always there. The magnitude of it will depend on how much stress are they experiencing in the environment. How much does the environment make them feel less capable or less competent? How much does it exacerbate those thoughts or feelings of helplessness or worthlessness or laziness? Those are environments where it's likely to be more prominent. Other environments it may be less prominent, but the thoughts will still be there, the feelings will still be there. They don't go away in different environments. Okay, good question. Okay, so that's major depressive disorder. Major depressive disorder is episodic. So basically what that means is there is an episode that's at least 2 weeks long. It can last months, but ultimately it remits. It goes away. Often it comes back, but the idea is that it's sort of, it comes, then goes, comes, then goes, and when it comes, it's huge, and when it goes, it's not there. Persistent depressive disorder, it's at a low level, but it's always there. So basically, we're looking at a mild presentation of depression, but it's almost constant. The duration of this tends to be, for adults, it has to be 2 years. For children, it's 1 year, where it needs to be at this consistent low level of depression for a year in order for a diagnosis to be made. the child can function. They can keep the depression fairly well hidden, but everything is burdensome, everything is slow, everything is difficult, everything is laborious. This is difficult to diagnose. It's a tricky one because it's such a low level. But again, we take a look at what's going on around the child. Before they were like this, were they different? And if the answer is yes, then we get suspicious that something may be going on. If it's proportional to long-standing and difficult circumstances, what we would consider adjustment disorder. Again, that's a technical classification. What it means to you is basically if the child is homeless, or if they're experiencing abuse or neglect or trauma, we wouldn't say they have persistent depressive disorder. We'd say they're having extremely difficult circumstances, and they're having a normal reaction to abnormal circumstances. So we're not saying that the child has to have no stressors in their environment, but extreme stressors tend to preclude a diagnosis because the focus is wrong. I wouldn't want to shift the child's negative thoughts if their negative thoughts are reflective of a really negative reality. We want to target their environment as opposed to those thoughts in that situation. So that's why we make those distinctions there. Okay. Disruptive mood dysregulation disorder. Have people heard of this one? This is sort of the new one. It was just added to the DSM-5. Basically, the question for this one is your child severely irritable and do they have frequent temper outbursts? There are two conditions that need to be met for this condition. The first is they have to have severe recurrent temper outbursts that are grossly disproportionate to the events that triggered them, and their mood in between those outbursts is persistently irritable. So this is different from the child who explodes and then they're fine until the next thing comes along and then they explode again. That's different. That's poor emotional regulation. It could be bipolar disorder in the extreme versions of that, but it's not this. The reason that this diagnosis was added is because bipolar disorder was being overdiagnosed in kids, because the presentation of bipolar disorder in kids was thought to represent more irritability, more explosiveness. And that is true. However, there's a subtype of presentation where, like this, in between episodes, they're still irritable. They're still upset. They're not coming back to a baseline. And that's not bipolar. And some studies have shown that if you treat that as bipolar and you medicate that child with bipolar medications, they don't get better. So it's a clinically useful distinction in determining how to proceed with treatment. If the child, again, has these huge temper outbursts, but then is able to go back to a baseline and be okay, that's something different. So it's the non-episodic irritability that's important between this, or in terms of this diagnosis. We don't make the diagnosis before age 6, largely because everyone before age 6 has temper outbursts and their mood is extremely unpredictable, so it's an unreliable indicator. Okay?
So I attended a seminar last week here on DMPD, and it was irritability and
Yeah, yeah.
So that is, you're saying this is that is clinically considered a form of depression and is treated. The treatments they're talking about there would be somewhat similar to what you were talking about here.
So the question was, having attended a previous seminar on severe mood dysregulation and disruptive mood dysregulation disorder, is this considered a subtype of depression? Yes. This is considered a depressive disorder. It's not considered a bipolar disorder. And so, again, this might seem like a wonky distinction, but it's just a way to help to classify the disorder and a way to inform the treatment. You know, if I see this as a diagnosis, it tells me to proceed a little differently than if I'm seeing bipolar as a diagnosis. It tells a psychiatrist how to proceed very differently. So it guides the treatment. Okay, before we go on, I did want to address bipolar disorders a little bit. Again, we could go into a lot of depth on them. The key distinction with bipolar disorders is that they're episodic, again, like major depression. Bipolar disorders generally involve some degree of elevated mood and some degree of depressed mood. There's a variety there's bipolar 1, bipolar 2, there's a cyclothymic disorder. You don't have to remember these, but what you have to understand is sometimes with bipolar disorder, there's a huge high followed by a very deep low. That's bipolar 1. That's your classic mania and major depression, okay? Sometimes there's a very mild high. We call that a hypomania, and then a major depression as well. That's bipolar 2. Sometimes it's kind of like low highs and minimal lows, and they're kind of vacillating between there. That's a cyclothymic disorder. So the key is that they're having an episode of mania and or an episode of major depression, and those episodes have a duration, and they begin at a time, and then they end at a time. And then you see another episode. So there's not that persistence. So The reason that's important is typically for medication purposes and determining which medications best work for the child. Clinically, if as a therapist, would I approach that differently? It kind of depends on the symptoms that we're treating. For someone with real mania, manic symptoms, that's hard to hide, and that could become part of treatment. That's very, very poor judgment, a sense of grandiosity. I can do anything. Again, very hard to diagnose in adolescents because that's kind of part of the developmental course. A huge degree of irritability, erupting, it's euphoria, but it's brittle. You know, kids extremely happy until one thing goes wrong and then they explode. And then it's followed by this inevitable descent into major depression. So if you see that pattern, that's indicative more of a bipolar disorder. I mention those just because the symptoms of depression are kind of woven into that. It's just not the whole thing, okay? You don't have to, it's okay if you're not walking away with a full understanding of, well, what's bipolar 2 versus, like, that's fine. Don't worry about it. Just understanding that that's a piece of the symptom profile that we might see, okay? Comorbidity is the term to indicate when more than one disorder is present. Comorbidity with depression is the rule rather than the exception. More than half of youth with depression also have another psychological disorder. Top ones tend to include anxiety, ADHD, ODD, conduct disorder, or an eating disorder. 20 to 30% of youth who are initially diagnosed with depression eventually turn out to have bipolar disorder. That's not the majority, but it's a sizable minority. So it's just recognize that it's not an either-or proposition. Is my child depressed or are they anxious? Often the answer is both, and you can imagine why. That if someone is feeling incredibly anxious and that's constricting their world and their environment, depression might inevitably come out of that. And if they're depressed, and if that shrinks their world, they may then fear situations where they feel more worthless or less competent and less capable, and so anxiety might arise as well. So these can feed off of one another. Okay. Talk a little bit about some statistics. Boring, but it'll give you a sense of how often we're dealing with these. Major depression affects about 1% of preschoolers, 2% of children, and up to 8% of adolescents. 20% of adolescents will experience meaningful symptoms of depression. What I mean by that is they're experiencing enough to have some sort of disordered functioning, but not enough to meet criteria for the disorder itself. So it just indicates just how prevalent this is. It's a very common condition, not the most common, but it's as you get older, it's particularly common. The incidence of depression, how many new cases occur each year, it's increasing. And the onset's occurring at earlier ages. What we're noticing in the schools in particular is that we're seeing more elementary schoolers who are showing symptoms of depression. It's concerning, and a lot of times you have teachers or school counselors who are being presented with these cases that they think are behavior conditions, and actually it's depression. Why is that trend happening? We don't know. It's an unsatisfying answer, but we're just noticing that it's occurring more often. Boys and girls have about equal risk of having a depressive disorder up until adolescence, at which time girls are twice as likely to show symptoms of depression. Again, we don't know what the reasons for that are. Biological, psychological, social, probably a combination of all of them. Yeah.
What statistics based on FCPS, or what's the source of these statistics?
These are national statistics.
National.
These are national. However, we do, so the question was, are there statistics for FCPS? And the answer is they're national statistics. However, we do, in Fairfax, we have a Fairfax County Youth Survey, which doesn't look at diagnosable conditions per se, but does gather data on certain problematic behaviors and certain protective factors. And I'll be sharing a little bit of that later on, but these are nationwide. Causes of depression. There's a variety of causes. We don't know exactly what causes it, but we do have a pretty good idea of some of the factors that are involved. So just to give you a brief overview, neurochemistry. The brain comprises nerve cells called neurons. They communicate electrically and they communicate chemically. Those chemicals are called neurotransmitters. There are three big ones in the brain: serotonin, norepinephrine, and dopamine. They have multiple functions. Among those are preserving and maintaining a positive mood. When neurotransmitters are disrupted in some manner, depressive symptoms can ensue. And when we talk a little bit about medication, we'll talk about how those medications are targeted at allowing more of those neurotransmitters to remain in the synapse, which is the junction between two neurons. So it's kind of like if you're taking a bath and you pull up, drain, and the water stays there. That's kind of what the medications are doing. They're allowing those neurotransmitters to stay in the synapse for longer before they get taken back in. Okay? That's one of the causes. Hormones. If you have a thyroid disorder, particularly hypothyroidism, lower levels of thyroxine, your symptoms are going to become very close to depression. There will be many others, but that's one element of that. So we know hormone fluctuations are involved in depression as well. This is also the case in terms of premenstrual symptoms, menopausal syndromes, postpartum syndromes as well. Depression isn't accidentally associated with these. The hormonal fluctuations can be a factor involved in that as well. Inherited traits. We know that from twin studies, identical twins are a lot more likely to have depression than fraternal twins. If you have a relative with depression, it makes it more likely. You don't inherit depression. There's no one gene that passes along depression. You inherit a combination of genes from mother, combination of genes from father. Certain combinations may make themselves more likely to lead to depression. So it's a predisposition. So you're not to blame if your child has depression. Let's get that out of the way right now, right? It's not your fault. But there are genetic contributors to depression. Early childhood stress, environmental factors as well. Early childhood stress, particularly abuse, neglect, trauma, actually changes the brain physiologically. And so the effect isn't just psychological, but physiological. There are higher levels of cortisol in the brain. Certain brain structures involved in regulating emotion tend to be smaller over time for children who are chronically exposed to these stressors. So these neurological effects manifest themselves psychologically as well. And learn patterns of negative thinking. If you continue to be taught either directly or indirectly to see yourself as having very little worth, to be a burden on others, to not be capable, to not belong, that over time can conduce itself toward a depressive syndrome or symptom. Yes?
Could some of the inherited traits come from other mental health disorders like schizophrenia or PTSD?
So the question was, can some of the inherited traits come from other mental health disorders like schizophrenia or PTSD? We don't know about the shared genetic patterns to say that whether the genes for schizophrenia are also the genes involved in depression. However, we do know that if you have one mental health disorder, you're more likely to have another mental health disorder. So someone with schizophrenia is at greater risk of depression. Someone with PTSD is at greater risk for depression as well. PTSD, interestingly, is something that can't be inherited because it's one of the only conditions that actually involves a response to an environmental situation. However, you can inherit certain temperament traits and or emotional regulation capacities that make you more vulnerable to that, because you might have a lack of resilience and a more difficult time being able to bounce back in the face of stress like that. So I guess the answer is that the more at risk one is for one mental health condition, the greater the risk likely is for other mental health conditions. Okay. Risk factors. These by themselves do not mean that anyone is going to come up with depression. If you ever look at risk factors for any medical condition, there's a huge laundry list. It's the more of these that are present, the more likely we are to see depression. Issues that negatively impact self-esteem, obesity, peer problems, bullying, and academic problems. The longer they persist, the greater degree to which they occur, the more likely we are to see a negative response to them. Being a victim of abuse, violence, having other mental health conditions, chronic pain or physical conditions, all of these probably ring true. Having a physical disability, having certain personality traits, low self-esteem, highly dependent, self-critical, pessimistic. Again, by themselves, not pathological. In combination, they can predispose someone to depression. Abusing alcohol, nicotine, or other drugs. This is another chicken and egg thing. Abusing drugs is much more likely to lead to depression. If you are depressed, you are much more likely to abuse drugs. So being mindful of that negative feedback loop that can occur. Being gay, lesbian, bisexual, or transgender in an unsupportive environment. This is an important risk factor that we need to know about. The rates of depression are significantly higher in individuals who identify as gay or lesbian. They are exceptionally high in individuals who identify as transgender. However, there are mitigating factors. And what has been found is that the degree to which the individual perceives their environment, and particularly the adults in that environment, as being supportive, is strongly associated with the degree to which depression emerges. So we see statistics to the degree that if someone is transgender but they feel that they're in a supportive environment, maybe 30% of those individuals may manifest depression, whereas if they don't feel that they're being supported in their identity, 70% will be. Now these are rough statistics, don't quote me on those, but they're not far off. So it shows the degree to which you as parents and caregivers have an influence over the kind of environments that you create. It doesn't mean that you can prevent depression, and it also doesn't mean that if depression exists, you're not doing that. But it means that that's one of the protective factors, particularly for vulnerable populations. We talked about having a heritable aspect, so close relatives with disorders, having a family member who died by suicide, a risk factor, experiencing ongoing family conflict, and having experienced recent stressful life events. Those by themselves don't lead to depression, but again, they increase risk by increasing vulnerability. Okay, so those are risk factors. Complications. Untreated depression can lead to a host of negative complications, including but not limited to alcohol and drug abuse, academic problems, family conflicts, involvement with the juvenile justice system in terms of acting out behaviors, and probably most significantly suicide. And at this point, I think it's important to talk a little bit more about suicide and what we need to know with regard to the risk there and how to address that. So national statistics on suicide is the third leading cause of death for individuals ages 10 to 24. It ranks just below accidents and I believe homicide. Of the 32,000 suicides of all ages in the US, about 5,000 are youth. This third one is pretty shocking. More teenagers and young adults die from suicide than from cancer, heart disease, AIDS, birth defects, stroke, pneumonia, flu, and chronic lung disease combined. For every youth who dies by suicide, about 200 attempt. We know that girls are significantly more likely to attempt suicide than boys. We know that boys are significantly more likely to die by suicide than girls. And that has to do with the lethality of measures that boys tend to choose over girls. The single largest cause of suicide is untreated or undertreated depression. Suicide by the Surgeon General has been deemed the most preventable form of death, and addressing depression directly and responding immediately can reduce the risk of suicide. Now, is suicidal ideation and or behavior present in everyone with depression? No. So I don't want you to think that if your child is struggling with depressive thoughts and feelings, that they must be suicidal and that you need to respond with alarm. And I don't present these to create a sense of alarm. I don't want people to panic from this. I present it to really honestly talk about the risk that's involved and to have an open and honest but not alarmist discussion about that. So recognize that suicidal thoughts range on a continuum from having passive thoughts about dying or wanting to die to having an active and specific plan about wanting to kill oneself. And clinicians respond with a much different series of actions depending on what they're presented with. Lots of people have thoughts, passing thoughts about death and or wanting to die. Is that concerning? Yes. Is it imminently concerning? No. In Fairfax County, we have a specific suicide risk assessment, the Columbia Suicide Severity Rating Scale, that all of our school psychologists, social workers, and counselors are trained in administering, that really helps to parse out the degree of risk anytime anybody indicates that a child is having suicidal thoughts and or behaviors. And depending on that degree of risk, we determine what to do. In all cases, parents are notified, but I specify that so that you know that if your child is saying, I've thought about dying, that's not the end of that conversation. You don't have to immediately jump to panic. You do want to take them to talk to somebody, and we'll get into that toward the end. But recognize that that sometimes is normal. We get very concerned if we're talking about concrete plans, we're talking about when I'm going to do it, what I'm going to do, what it's going to look like. I'm going to write a note, I'm going to give away possessions, things like that. So know that it's common. Don't be alarmed by it. And one of the things that I'm going to mention later on, but I'll give you a kind of prelude into, is talk to your child about it. Talking about suicide does not plant the idea in their heads. I promise you, it won't happen. It's the thought that has been kind of one of the arguments against sex ed, is if you talk about sex, kids are going to start thinking about sex. They're already thinking about sex, independent of you talking about it. And you talking about it is actually going to make them think about it less. So don't be alarmed about that. And the same principle applies for suicide. They were already thinking about it. They've already heard about it from their friends. They watch the news. They have social media. They see what goes on. Okay? You're not going to plant the idea. You are going to let them know that you're concerned and that you want to have these conversations with them. Okay? So what do you do if you've got concerns? There's going to be, this is the smaller version, and I'm going to give you a little bit of a kind of follow-up version at the end of this as well. Talk to the pediatrician to rule out medical conditions that might be causing depressive symptoms. I don't know if I'm a therapist and you're taking your child to me if there's something medical that's going on, so it's always good to rule out potential medical causes, getting a physical, making sure everything is up to par. Talk to the school counselor, social worker, or psychologist. All of the schools in Fairfax County have one or more counselors, and they have not always full-time, but designated school psychologist and school social worker. Talk to them, use them, avail yourself of those resources. They operate both independently and as part of school teams, and both you can meet with them one-on-one, independent of a meeting, or you can say, I'd like to meet with a child study team, or I'd like to meet with the school team to discuss my concerns. I'm not going to speak to any individual cases. I'm sure there are people in this room who are thinking, I've tried that, and they're still struggling, or some who have had great success in doing that. I can't speak to any individual cases, but what I can say is the better the communication is between home and school, the more likely you are to lead to positive outcomes in response to whatever it is that your child is struggling with. Schedule an appointment with an outside specialist. This may seem basic to folks, but I do want to make the distinction. Psychiatrists are medical doctors. They have an MD, they go to med school, and they specialize in, at this point, mostly the prescribing of medications. Some therapists provide therapy. It's becoming more and more rare at this point, and what you have is sort of a kind of bisected system where psychiatrists are providing the medication management, and psychologists, counselors, other therapists are providing the therapy. So just so you know who you're talking to and what you're expecting to get out of those interactions. I've had lots of people say, so do you prescribe medications? And no, we don't. All of them are important in the management of depression. There are a variety of resources out there. However, I'll be the first to acknowledge that the resources that exist in this area are not enough to meet the need that exists in this area. And so that hopefully will change as more and more people are trained in these professions. But we acknowledge that there's a high need. There's a wealth of resources, but this is a heavily populated area. And a lot of times you're going to be put on wait lists. And so that's a concern. So I would say do that, but don't just do that. That's why I go back to bullet number 2. Talk to the school, get some resources, talk to them about how you might be able to set up appointments.
What is the difference between the counselor and psychologist? That I'm not so clear on.
So the question was, what's the difference between a counselor and a psychologist? Training is really the difference. Both a counselor and a psychologist can provide therapy, so can a licensed clinical social worker, and so can a licensed marriage and family therapist. There's about 6 different kinds of degrees that can allow people to be able to provide the therapy. Really, it's just there are subtle differences in training. Psychologists can or are more likely to be doctoral level, depending on that training, and might have broader training in learning and behavior rather than mental health, but not always the case. Clinical social workers, licensed professional counselors can also provide mental health treatment. And I think the best way to assess the training is look at their bio, look at the website. They're not always as hard and fast the distinction. The biggest one is between a psychiatrist and kind of everybody else.
Yes, because when I look at the providers in the mental health services that my health insurance company provides, we will have both psychologists and these counselors and licensed.
Right.
Counselors. So I get very confused whom to choose.
So yeah, when you're looking at the resources that are given to you, the question was a lot of times it's confusing when it says psychologist. In some cases it says counselor. It is confusing. I am a psychologist, and so it would seem biased for me to say psychologists are better. They're not always better, but there are some subtle differences in training. So really what I would recommend is go to the website, call them, ask them, is this a condition that you are equipped to be able to treat? Here are my concerns, what could you do with them? All right. First steps, independent of seeking out any additional help, create a stable, secure atmosphere for the kids in which they feel safe. Encourage your kids to talk to someone about their feelings. Ideally you, but other people as well. And be compassionate. I figured I'd give you 3 easy ones to start with. Don't attribute the signs to attention-seeking behavior. This is important. If your child is showing depressive signs and symptoms in order to gain attention, they need attention for something. They might not be going about it the right way, and you might want them to ultimately learn skills to gain attention through more adaptive and pro-social means. But it doesn't mean that the need isn't there. So you want to acknowledge that need, and then we can deal with how it's presenting itself. Don't try to minimize or explain away the problem. It's not that big a deal. You'll get over it. Don't worry about it. We've all been there before. Why don't we say these things? We don't say these things because they tell the child not to trust what it is that they're feeling. It tells the child, my feelings aren't valid. I shouldn't be feeling what I'm feeling. I should be able to get over it. I should just man up. And then they do one of 2 things. They inhibit those feelings, and then those feelings fester and expand, or they ramp up what they're doing to the point when you can't ignore it and you have to respond. So one of the things that we notice as therapists often is you will have a child who is showing these depressive symptoms, and they're showing some acting out behaviors, and the parents are sort of ignoring and ignoring and ignoring, and then finally they cut themselves, or they make a suicide attempt, and the parents go, oh my God, we've got to take you to a mental health professional now, I'm so sorry. And what does that teach the child? It teaches them, in order for my parents to pay attention to me, I have to take my behavior to this level. So pay attention to it even when it's at lower levels. Validate the feeling. You don't have to validate the behavior, okay? If they're yelling at you, or they're screaming at you, or they're breaking dishes, you don't have to be like, I'm so glad you're doing that, or that's a great way to express yourself. You can say, it seems like you're feeling really upset right now. And you can validate that feeling, again, without necessarily condoning the behavior that's going on. Don't deny the seriousness of the issue, and don't take your child's behavior personally. What I don't want you to think is, how can you be so depressed? I provide all these things for you. I take you to sports, and you have play dates with your friends, and I buy you toys, and I put a roof over your head, and I feed you, and yet you're depressed. It's not about you. It has nothing to do with that, okay? Depression doesn't really discriminate. You can have people who are the most loved and provided for children who are feeling depressed. You can have people who are in the most austere and desperate circumstances who are depressed. Don't make it about you. Don't take it personally. It's not about your lack of ability to provide for your child. However, do listen, because there might be useful input involved. And if your child says, I feel like you just don't listen to me or don't understand me, don't respond, how could you feel that way? Look at everything that I do for you, because their perception might not map onto your perception. So keep an open mind with those things. Those are harder ones, I acknowledge. Treatment for depression. I'm not going to go in depth into this. There are a whole host of acronymic therapies that have been proven effective for treating depression. Many studies have shown that psychotherapy is effective at treating depression. What tends to be most effective at treating depression is a combination of medication and psychotherapy. Psychotherapy alone is better than nothing. Often psychotherapy alone is better than medication alone, unless we're dealing with severe depression, in which case it's reversed. Medication tends to be more effective than therapy alone. When you combine them, it tends to work the best. I'm not advocating medication by itself. I'm not advocating medication at all at this point, except to say research has shown that it tends to be effective. There are side effects associated with it. We'll get into that a little bit later. A lot of therapies now are going to deal with addressing your child's thoughts, their feelings, and their behavior. So cognitive behavior therapy, CBT, is what you're going to hear a lot. It's extremely popular now. It's extremely effective at addressing the thought patterns that tend to be involved in depression that we talked about earlier, teaching your child to be aware of those thought patterns and teaching them to challenge some of those negativistic patterns of thinking. Some examples might be black and white thinking. Either everything is all good or it's all bad. Examples might be overgeneralization. This thing went bad, therefore everything else is bad. Teaching them to spot those things and then challenge those thoughts, and then gradually reshape the way that they think about themselves and their world. It takes a lot of time, but it's been shown to be heavily effective. Interpersonal therapy, targeting interpersonal relationships and the context in which depression occurs. A lot of people, by the way, won't advertise themselves as being, I'm an interpersonal therapist or I'm a cognitive behavior therapist. A lot of times they'll do a mix of them, but ask. You can ask, what treatment modality do you use and how will you be doing this? DBT, dialectical behavior therapy, drawing upon cognitive behavioral principles, also looking at emotional regulation. What are the skills needed to be able to be mindful of my current circumstance, tolerate distress when it comes, regulate my emotions when they feel out of control, and have effective interactions with the people around me. Acceptance and commitment therapy, which is actually called ACT and not ACT. If you talk to a therapist and you call it ACT, they're going to think that you really know what you're talking about. That's a more complex version of some of the above, where it's dealing with certain mindfulness skills as well as certain cognitive reappraisal skills, as well as committing yourself to certain value-oriented actions. All of those, again, we could explain in great depth. You don't have to know all of them, except to know that these tend to be the ones that are associated with the greatest effect, and that's because they're targeting a whole variety of the factors that are responsible for causing depression: the thoughts, the feelings, the behaviors, the contexts as well. Family and group therapy are sometimes indicated as well, sometimes by themselves, sometimes in conjunction with individual therapy. All of them have been shown to be effective. In schools, so if you ask the school psychologist, counselor, social worker, can you provide therapy to my child? The direct answer is no. The indirect answer is kind of. They're not going to be able to say, I can treat your child's depression. What they can tell you is, I have certain curricula that are drawing on evidence-based practices that I can implement with your child that have been shown to be effective for kids with depression. That might sound like a really roundabout way of saying the same thing, but it's because for the school system, they're charged with improving your child's educational functioning. Education is not limited to academics, but really it's focusing on how are they adjusting at school. We have a lot of evidence-based practices. Some of them are manualized curricula. Others are just drawing upon cognitive behavioral principles, for example. But our school-based counselors and clinicians have access to and training in a variety of these programs and practices, and can and do implement them pretty regularly in the school setting. So don't be afraid to talk to the school and ask what can be done at a certain level to try and address some of these concerns. I wouldn't recommend saying, I want you to do this program based on this thing, because you want to have it be a discussion. But there are school-based, I won't say treatment options, but I'll say intervention options that are available. Yes?
Is that available even if the child is not falling behind academically?
Can you say that one more time?
Is that resource available even if the child is not falling behind academically?
The question was, is that resource available even if the child is not falling behind academically? Yes, it is. You can have, if we look at difficulties in school as falling within one of three really broad categories: academics, behavior, and wellness. Academics can be fine, but behavior and or mental wellness can be poor. And so we would expect that the school would be able to provide some sort of accommodation and or intervention to address that. That doesn't mean special education. Sometimes it can, but it doesn't necessarily mean that. But it means that if a child is struggling emotionally to adjust, even if they're achieving well grade-wise, they can still have access to these. It's a discussion. I'm not going to tell you that, Dogwood Elementary School can provide these interventions, but they are available. Okay. Medication. We talked about medication effectiveness. There's many different types of medication. Antidepressants are the most common for depression, as you would imagine. Those operate by some of the mechanisms we talked about earlier in terms of affecting the different levels of neurotransmitters. SSRIs, selective serotonin reuptake inhibitors, are some of the most common ones. Those are your Prozac, Zoloft, Paxil, Lexapro, Celexa. Some of them affect norepinephrine, Effexor and Cymbalta are two examples of those. Some of them affect dopamine and norepinephrine. Wellbutrin and Remeron are examples of those. You don't have to remember any of that, except to know that the different antidepressant medications affect the reuptake and the presence of these chemicals in the synapse of the brain. And so basically, they're allowing these mood-regulating chemicals to be present for longer periods of time. Mood-stabilizing medications for bipolar disorder, those are things like lithium, Depakote, valproic acid, a bunch of others that operate under somewhat different premises that psychiatrists can describe more effectively. Sometimes those medications are used as an adjunct to antidepressant medications if that alone isn't effective. That's a decision not for any of us to make, but to discuss with the medicated provider. Again, I'm not going to talk about whether or not you should put your child on medication. I know that people have a lot of qualms, rightfully so, about them. Medications have side effects. They do. One thing I want to address, though, is a little over a decade ago, there was a black box warning that was put on antidepressant medications, which basically said, be cautious if you're giving these medications to children under the age of 18 because they can potentially increase the risk of suicidal thinking. That's true. There is a small percentage of kids and adolescents who, when put on the antidepressant medications, do show an increase in suicidal thinking. However, in the year after the black box warning was put into effect, rates of suicide skyrocketed because people weren't prescribing them as much and parents weren't seeking out the medications as much. So what I want to emphasize to you is that the risk of suicide is far greater with untreated depression than it is with being on depression with a risk of suicide. That's not telling you to put your child on medication, but it's putting that black box warning in the context, which is to say the risk of suicidal thinking and behavior when going on a medication is significantly less than the risk of suicidal thinking or behavior when not being treated and being depressed. Okay? Yes?
Going back to your psychotherapy, you had a number of therapies that you have listed there. Who decides what applies and what's effective?
So the question was, looking at the different psychotherapies, who decides which therapy to apply and how to structure treatment? The answer is your treatment provider in conversation with you. Your treatment provider will, if it's a therapist, again, psychologist, counselor, will look at the symptoms that your child is presenting with and will decide based on the presentation and based on their expertise, I think that this is the way to go. Some treatment providers will say, this is the treatment that I do. And you have to decide with them, and they'll hopefully be able to tell you whether their method of therapy can meet the needs of your child. So you don't have to feel like you have to go in there armed with the knowledge of what therapy is best for your child. The therapy that might be best for your child will depend on their needs. I can't tell you up here which one of those would work best for your child depending on their needs. It's going to depend on their specific circumstances. So it should be a conversation between you and the treatment provider. Know that those are treatments that work. Which one of those is indicated will depend on the specific circumstances. Okay.
Can they detect depression by testing in laboratory the amount of cortisol and the other things, the other hormones that you are carrying?
So yeah, the question was, can depression be detected in laboratory tests of hormones like cortisol? We're not at that level yet. To my knowledge, there are no blood tests that can indicate depression. We can detect elevated levels of cortisol, but that just tells you that there's higher levels of stress in the body, and it doesn't tell you what that stress is caused by. We are advancing daily in our ability to identify biological markers of psychological conditions. And so there's genetic testing out there that can not tell you whether your child has depression or tell you which medication specifically is right for your child, but it can tell you a certain class of medications may be more effective for your child than another one. So we're getting closer, but we're not yet at a place where we can say, because your child has this hormone or has this gene, they will have depression or they're more likely to have depression. But if you ask me again in 5 to 10 years, that answer may change. Okay?
Just following her question, one of the causes of depression can be neurochemistry or hormones or something like that. So how we can address that with the pediatrician, for example? What should we ask for? Sometimes they need questions.
So the question was, if one of the causes of depression is neurochemistry, and or hormones, how do we address that with our pediatrician? I think I would start by asking the pediatrician, my child is showing these symptoms, what do you think? So I'm presenting you with all of this information to take with you, but I also want, when you go to your treatment provider, start with just the symptoms. What's harder for me, if someone tells me, I think that my child's dopamine levels are off, I have no idea what to do with that, okay? But if you're telling me my child is withdrawing more, and my child is having a harder time at school, and my child tends to blame themselves a lot, I can work with that more. So where we go with it in terms of hormone levels and or brain chemistry, that's where I would say if their hormone levels are off, a physical exam should be able to account for that. So if you go to your pediatrician and say, my child is showing these symptoms, they might say, let me run some blood tests. All right? And then they can rule out some of the more common medical conditions. And then if we rule those out and the symptoms remain, then they might say, maybe you need a referral to a therapist and or to a psychiatrist. Typically, pediatricians will not prescribe antidepressants themselves. Sometimes they will, but more often they'll refer out. And so you rule out the common medical causes, and then you'll go to the specialist there. So you can ask those questions, but start with what you're seeing objectively, rather than what we're assuming that might be caused by. Okay? Okay. Some things that you can do, we're finishing up here. Know your child and their friends. It's okay to be a little bit pushy with this one. Know who they're hanging out with. Know what they tend to be involved in. Be active, be involved. This is a protective factor, knowing more of what's going on in your child's life. Be actively involved with your child's school. Have a positive homeschool connection. Again, really important protective factor there. If a child has at least one adult who cares about them, who they believe cares about them and asks about how they're doing and shows an interest in their life, that can serve as a protective factor against stress and other mental health conditions. Know the signs and symptoms of depression and monitor your child. Participate in parent training sessions. You can check that one off. Learn about the resources that are available for obtaining an evaluation if you suspect a problem. School-based evaluations exist. They won't evaluate strictly for depression, but they will say we can maybe evaluate if we suspect a disability that might require services for special education. That's an entirely separate presentation, but it's enough to get you started on that process. There are private evaluations as well that can look at the presence for depression. You can diagnose depression without a huge full battery of tests. However, sometimes if we're dealing with a complicated situation, you might need more assessment measures to determine what it is that we're dealing with. Be active in developing and participating in the treatment plan if your child is diagnosed. Be a part of it. Don't kind of just put that off on the treatment provider. You're an important part of your child's treatment. Monitor your children for suicidal thoughts, statements, or plans, particularly if you have concerns already that exist about them. I'm going to go back to the statement, talking about it is not going to prompt those thoughts. Make sure that guns, medications, and lethal implements are not accessible. This is an important one, particularly if your child is diagnosed with depression, especially if your child is diagnosed with depression and has or has had suicidal ideation. Keep the environment safe. One of the things that's particularly important in terms of medication that might not seem immediately intuitive is some over-the-counter medications are extremely dangerous. Tylenol is the most common one. So if you have a child who has expressed suicidal thoughts and or who has acted on suicidal urges, lock up the Tylenol. If you overdose on Tylenol, you need very quick action in order to prevent a toxic response. It is very easy to either die from an overdose of Tylenol or damage your liver to a permanent degree. So that's just a small thing to keep in mind. Not everybody who is suicidal is going to act on that, but just be aware of the things in your house that can do harm, and just be mindful of keeping a close eye on those. Don't hesitate to ask about suicide, drugs, alcohol, or problem with bullies. Again, be involved, be proactive. I'm including some resources there. These are some websites that in your handouts could be good to seek out additional information. Don't go on those websites and read a lot of scary information and panic. Don't go on those websites and diagnose your child after going on those websites because of all that. Use it to enhance your knowledge, but don't use it as the sole source, okay? I went on NAMI and I saw that these were the symptoms, therefore my child must have bipolar 2. You know, use it, but don't take it to the extent that it drives your entire decision making. Have those conversations with other professionals, okay? So we've got about 12 minutes till 8. That's the end of the structure presentation, and so I'll open it up to additional questions. Yeah.
I want to start by saying thank you so much. It was very informative, and thank you so much. You talked a lot about what can parents do, and you also mentioned a little bit about how schools can help. Let's say the child or the teen is already diagnosed with depression and mental health issues. What is the school providing for the student here in FCPS that's helping the student deal with this issue?
That's a great question. So if your child is already diagnosed with depression or mental health issues, what is the school doing? The answer depends on how much it's impacting the child at school. And it will range from nothing to an IEP with multiple hours of special ed support in a specialized setting. The reason there's that range is because a lot of students who are depressed are not showing the impact at school, or they're showing it to varying degrees. So what I would say is, if your child is diagnosed and you are looking for support from your school, the first step is, if they're not receiving any services, talk to the teacher or the counselor and mention that they have this diagnosis, share with the school that information, and say, here's what I'm noticing, here's why they have this diagnosis, here are the symptoms that we're seeing. What are the things that you can do to help them? And they might say, tell me about what your child is saying or doing at school. You might want to talk with the child's teacher, particularly if they're in elementary school and there's just one teacher, with their counselor if they're in middle or high school, to get a sense of, are those symptoms coming through? Sometimes if you talk with the teacher or with the counselor, they might say, you know what, we've noticed those things, we just never really knew what to make of it. And if you say, now they have a diagnosis of depression, that might put it in context for them. The supports that are available range pretty widely, from just having someone to check in with on a regular basis, which can be surprisingly powerful at the beginning and the end of the day, just checking in with someone, to some of these evidence-based programs that we have available, where they're manualized curricula that they could implement in a small group setting, where a counselor or social worker or psychologist can pull the child out with some other peers of similar or ranging grade levels and implement different lessons on a regular basis that can address depression or other mental health conditions. And in some cases, if it's implementing or impacting rather their ability to function to such a degree that they're really struggling, not just academically, but in terms of their well-being at school to such a significant level, they may look at doing an evaluation for special ed services. And they may look at implementing, if they're eligible, an IEP to target certain social, emotional, and behavioral goals, and to have certain plans for meeting those goals. That's a range of services and supports, and sometimes I know that the school system can be very difficult to navigate in terms of what's available, and different people are at different schools. So I would say always start the conversation, and in terms, ask what is that's available at the school, and say, these are the things that I'm concerned about. How can we work together to meet those needs? I can tell you that there's a variety of resources available in the school system. I can't tell you specifically at your child's school what they have, but I can tell you that they can get access to just about anything. So,
I mean, the one thing that comes to mind, and again, I'm not pointing to any
sure.
school. I'm a special ed teacher
Yeah.
in FCPS, so I love my work. But there is a tendency that I have observed over the years that sometimes with mental health issues, if the child is receiving therapy and services outside the school immediately is saying that, you know what, this child is receiving counseling outside, we do not need to service that child.
Mm-hmm.
And that's why I'm bringing this up here as a parent
Right
now, because I feel like just because the child is receiving services outside the school should not impact the decision of that child receiving the services inside the school.
Right. So that for those of you who might not have heard, the statement was, if a child is struggling with mental health concerns but is receiving treatment outside of school, sometimes the response from the school may be, well, we don't need to do anything because they are receiving that treatment. And the advice that was given was, just because the child is receiving those supports outside of school doesn't mean that they don't need help within the school. I don't have anything to add to that. I agree wholeheartedly. Yes, that's true. Just because they are receiving treatment outside doesn't mean they don't need help. And in fact, I think that in those situations, it's best for the outside treatment providers and the school staff to communicate. Get a release of information signed, have them talk with one another so that the treatment in one setting is being capitalized on and benefited from in the other setting as well. And that the school can learn from what the outside provider is doing, and the outside provider can learn from what is going on at the school. because they only get to see that child once a week or once every 2 weeks or once a month, and the school sees them every day. So we want there to be that partnership between the two of them. And when I was working in the schools, I regularly was talking with psychiatrists and psychologists and therapists and counselors and people of a variety of different criteria because I welcomed their expertise and information, and they welcomed my vantage point of seeing the child on such a regular basis.
Are you looking at the role of social media with these students in the rise of depression?
Are we looking at the role of social media in the rise of depression among our youth? Yes. Social media is a mixed bag. It has done wonderful things for our ability to connect and communicate with people, and it's a huge risk factor. There are studies that have been showing that time on social media tends to correlate with depressive symptoms. That doesn't mean that Facebook or Instagram causes depression, but if you look at it, Facebook, Instagram, Twitter tend to be idealized portraits of people. People present what they want to present. Typically, they're showing pictures of them with their friends. They're showing all of the likes that they get. It highlights the things that are going well. Most people, some do, but most people are not posting all of the things that are going poorly for them. And so it creates an artificially high comparison point. And so then there's this pressure of, I need to have this many friends or this many likes, or if I don't, then there must be something wrong. And so it can serve to, it's kind of like it's a blank slate, but it can serve to magnify whatever insecurities you've got. You can find them refracted through social media. It doesn't mean social media is bad by itself, but if you have a child who's at risk for depression or who's demonstrating depressive symptoms, you will need to monitor their social media use and talk with them about that. I've had some adolescents who I've worked with who we've said, I think you need to get off Facebook and Instagram. I think you can't be on it right now. And some of them have agreed because they'll realize it's too much. The negative comparison points, the drama that they can get into, just the simple fear of missing out. You know, I need to check all of my accounts because I might have missed someone who posted something, and then I'm going to be behind, and then I'm not going to know what's happening. And it's generating far more stress than it is creating enjoyment. So have those conversations, have them gently. Your kids are going to resist you on that one. But it is an important factor, particularly in today's world.
Encouraging our children to openly communicate with a counselor or a therapist, but what can a therapist and counselor share with the parents that we might be concerned with?
So the question was, what can the therapist and counselor share with the parents? What I would ask is, in terms of helping your children to communicate?
Not so much that, but if there are concerns that the child is expressing to the therapist that they may not be expressing to the parent, is that something that you share?
Oh, I see what you're saying. So I think you're asking a question about confidentiality. Okay, so if a child expresses concerns to a counselor or a therapist, can those concerns be expressed to a parent? That's a really good question. The rules are a little bit different in the school than they are in a private outpatient setting, and I'll talk about both. If a child is expressing concerns to like a school counselor or school psychologist, school social worker, they have broad latitude to share any information that they might see as concerning, and they are required to share any information that they think represents a harm, potentially, to the child. So if the child is indicating anything that suggests that they might be doing harm, this includes, if they're doing, opiates or hard drugs, or if they're drinking, if they're potentially involved in gangs, or even if they're having certain suicidal thoughts, without even a plan, there's a requirement to report that. If they're coming to their counselor and they're saying, I'm feeling sad, do they have to report that? Not the first time, but a counselor can't continue to see a child without parents' consent. And that's where you get around that at the school, is that they would need to contact you to say, look, I've noticed these concerns with your child. I think it might be good to touch base with them more regularly, but I need your consent to do so. And then they can share with you. So you're likely to get a lot more information from the school-based professionals because there's not the same kind of strictness of confidentiality surrounding that. From outpatient providers, under 18, they're not bound by those laws either. I mean, you ultimately have the say. Children, you want to provide children with some degree of confidentiality so they feel that they have a safety. to disclose things without everything being reported back. But ultimately, if you press, the therapist will have to reveal to you what it is that's going on. And the therapist, I mean, I can't speak for everyone, but I can tell you that I would want to tell the parents what's going on because you're one of my most powerful allies in helping to treat the child. So I would want to disclose that much more. If you're dealing with 18 or older, that's where it gets tricky because that's where outpatient, you have no right to know what's going on. And the therapist is mandated to not tell you unless the child specifically gives consent. But I'm hoping that most of the people here we're talking about are 17 and under, and therefore you have broader latitude. But if you're concerned about that, I would talk with your child's therapist and or counselor to say, look, I know that they find you a safe person, and I'm glad that they're disclosing. I'm concerned that they might not be sharing as much with me. Can you keep me updated on any concerns and or directions that you're seeing this going so that I know how best to respond to that? And you're likely to get a positive response to that. Okay. Yes.
My question is when you have students that are 18 in the public schools, like we had the issue with the shooting, the counselor didn't tell the parents because he was 18 and in the school, and that's kind of a concern for a lot of us parents is, yeah, they're 18 and they've got rights transferred to them, but if they're still in high school, I would love to see that law change, at least in the Commonwealth.
And what I would say is that if they're 18 but they're still in school, you should still be telling the parents because they're still a student.
Yeah, I would like
You know.
to see that.
Yeah.
It is concerning.
Yeah,
They're
no, I
18,
understand.
But I consider them still a kid.
And what I would also say is that if there's ever any concern about harm, therapists are protected in the sense that they can break confidentiality without recourse. The other thing that I'd say is that if they're in the school counselor is not their therapist. So there's not the same law that's protecting them in that particular case. So there's much more latitude to be able to disclose. Again, I can't speak to specific incidents, but what I can tell you is that there's not, they can't say, it's, therapist and patient confidentiality because they're not the therapist and they're not the patient. They're a student and they're an educational professional. And so we're looking at different laws governing that. So I agree. All right, well, it's about 8 o'clock, so I'm going to let people go. I'm going to stick around for a few minutes afterwards to deal with questions. But I'd encourage you, if you have additional questions, talk to your outside professionals, pediatrician, school counselor, social worker, teacher, psychologist. Talk with your school team, okay? Thanks.